Thank you for joining the Friday presentations of the 2021 Biomedica Oncology Summit. My name is Ben Pfeiffer, and my presentation today deals with new immunotherapies combined with complementary oncology measures. This is a collaboration effort with Professor Handgradinger from the University of Tübingen in Germany and Professor Thomas Vogel from the University of Frankfurt, both respected and well-known medical specialists in Germany and also beyond in all of Europe. I want to start with a number game. Looking at an adult human, we assume that it consists of about 35 trillion cells. That is a 3.5 times 10 to the 13th, or a 35 with 12 zeros after it. Almost 70% of that are red blood cells. And in addition to that, there's 40 trillion non-human cells living in us, bacterial cells, various other microbes, viruses, and so on. Every day, about 4 times 10 to the 10 of our cells die and are replaced by new cells. Replacement is orchestrated by our adult stem cells present in all the 200 plus tissues that our human body is made of. Assuming 80 years of life, this is 30,000 days times 4 times 10 to the 10th, or about 1.2 times 10 to the 15th. That results in a number of more than 1 quadrillion cell replacement in our lifetime. Now, it becomes pretty clear that with so many cells replacements, DNA copy errors may happen, resulting in mutations and sometimes development of cancer. Adding the environmental pressures through thousands of carcinogens in our daily life, bad nutrition, immune depression from negative stress, it becomes clear that something can go wrong. And this slide shows you that mutation, when they accumulate in our cells, can lead to the generation of a first cancer cell, which then, by clonal evolution, may form a small cancerous growth and end up in metastatic disease. This will make us understand the world's present cancer statistics probably a bit better. There is more new cancer cases and cancer deaths every year. This slide shows you in blue columns the new cases every year. And you see in 2020, so last year we had almost 20 million new cancer cases on the planet. Looking at the brownish colored columns, then you can see that this also is increasing. In particular, the 2020 numbers are an estimate, but we had about 10 million deaths in 2020 from cancer. Our immune system, of course, plays a major role in protecting us, not only against bacteria, parasites, and viruses, but also against cancer. On the other side, it must tolerate self. That means it must not attack healthy cells. There is a very delicate balance, and when this is disturbed, infection, cancer, or autoimmune disease may develop. Some facts of our immune system, which operates 2 main immunity strategies, please allow me to repeat. There is an innate immune system, and the major function and players are listed underneath. NK cells are the main cellular component, but there is also a complement system and cytokines that are important in innate immunity. This system provides physical and chemical barriers to infections. It recruits immune cells through cytokines to the infectious site or to cancer sites. It activates adaptive immune system through antigen-presenting cells, and it works immediately upon contact with a non-self antigen. On the other hand, there's an adaptive immune system, and antigen-presenting cells, T cells, and B cells are the main cellular components. In addition, there's cytokines again, and also antibodies created by the B cell response. This system recognizes non-self antigens in the presence of self, and it only attacks non-self and not self in the ideal situation. It orchestrates immune responses to eliminate pathogen-infected cells, but also cancer cells. We'll talk about this in the cancer immunity cycle slides. It creates immunological memory B cells, memory T cells are the cellular components of that. And it needs some time for creating a significant immune response, usually 5 to 7, in some situations also more days. This slide shows the so-called cancer immunity cycle, first published by Chen and Melman in 2003. It is very instructive because it gives an idea how the adaptive immune system is functioning during the fight against tumor cells. The first step in this cycle is liberation of cancer antigens. This could happen spontaneously or through treatment effect. Treatments, for example, radiation or hypothermia, can destroy certain cancer cells and liberate antigens from those cells. These antigens will then be taken up by so-called antigen-presenting cells, for example, dendritic cells, but also some macrophage are able to do that. And they will present those antigens on the cell surface to lymphocytes in the lymph nodes. Well, for that process, adhesion and activation is necessary, and antigen-presenting cells interact closely with the T cells in the lymph nodes. From there, the activated T cells will then migrate through the blood vessels to the tumor site. And in step 6, they will actually migrate into the tumor cells, into the cancer, recognize the cancer cells and bind to them. Again, this happens through certain proteins on the surface of cancer and of lymphocytes we will show later. And step 7 is finally and eventually killing of the cancer cells by the cytotoxic T cells. Now this cycle repeats itself, but there are certain checkpoints built in. One is here, between antigen presentation to the T cells, and a second one is built in over here at the cancer killing site. We will see those checkpoints in this slide. On the left-hand side, you see antigen presentation to T cells. And there's a certain interaction that is magnified down here. And you see that first it has to come to a binding of the T cell receptor with the MHC or HLA receptor protein on the dendritic cell. After this binding has happened, a receptor protein called CTLA4, that is seen here, and the connection to the dendritic cell B7 can then be inactivate the dendritic cell so that the activation of the T cell is not happening. But we can block this, of course, by a so-called CTLA4 antibody, and we will use that as checkpoint inhibitor to increase our immune response at that step. On the right-hand side, you see the tumor microenvironment. And here again, you have the T cell, but not reacting with the dendritic cell like on the left, but reacting now with the tumor cell. And here again, the first step must be a connection between T cell and tumor cells through the MHC of the tumor cell and the TCR receptor on the T cell. When that happens and the inhibiting site, that is a PD, death receptor, for example, is blocked by an antibody, then the full force of that activated T lymphocyte towards the tumor cell is free and the tumor cell can be killed. However, if we are not blocking this inhibitory site of the PD-1 and PD-L1 receptors on the tumor cells or on the T cells, then of course T cell killing is weaker, and after a couple of cycles it will kind of stop. So we have these checkpoints built in to protect overshooting immune responses, and we can block those checkpoints to increase the immune response against cancer. James Allison got the Nobel Prize in 2018 for his findings of these checkpoints and their possible blockade. Well, today we have already certain medications approved that are based on the CTLA-4 inhibition, for example, ipilimumab, or based on PD-1 inhibition, for example, Opdivo, nivolumab, or pembrolizumab, Keytruda, or on inhibition from PD-L1. These are the ones on the tumor cells. Let's look at some facilitating and inhibiting factors that also mitigate the speed of this cancer immunity. There is facilitating factors, and I marked them all green here, and many of those are cytokines that speed up the cycle or make it happen. And then there are inhibitory factors, and they are marked red, and the balance of facilitation and inhibition of all these factors determines whether actually tumor cell kill in the end will happen or not. This cancer immunity cycle can also be used to define resulting treatment possibilities or applications. On step 1, we could of course use low-dose chemotherapy, radiation, or thermoablation, hypothermia treatments, for example, to liberate more tumor antigen for our dendritic cells to capture and to show to the T cell system. Now, on step 2, we could apply vaccination technologies, loading those dendritic cells up with tumor antigen. We could also use cytokines to speed up the presentation and the adhesion of the dendritic cells to the lymphocytes. In step 3, we could make the activation of the lymphocytes, meaning T lymphocytes, better. Then we could get anti-VEGF on the infiltration side. That means allowing the activated T cells to migrate better through the vessel walls and into the microenvironment of the tumor. And finally, at step 6 and 7, we have also possibilities to intervene and use those steps to design far better activated and stronger T cells. For example, CAR T cells. And finally, at step 7 of the cycle, we could use checkpoint inhibitors, for example, anti-PD-L1, anti-PD-1, to accelerate cancer cell killing at that step. Now, this sounds all very promising and good, but cancer cells are smart biological entities, and they have various escape mechanisms to avoid killing. For example, they could just lose their antigenicity. That means the cancer cells do not express HLA typical for cancer cells, so our immune system doesn't see them. They could also block their antigenicity and lose immunogenicity. For example, they can overexpress PD-L1 and not allow the interaction between the activated T cell and the cancer cell. And last but not least, they can call a lot of other immune cells into the microenvironment of the tumor, for example, T regulatory cells and macrophages that are actually inhibiting the immune cycle that we just saw. So, cancer killing, after all, is not that easy. Nevertheless, a strong immune system is by far the best guarantee for healthy aging without any cancer. But unfortunately, it does not protect against weak street science. I want to show you some patient examples. Now, I will not do what's usually done in these presentations, only the best cases are seen. No, I want to show you some good cases, but also some sad cases from which we can learn. Here, the first patient is a 53-year-old male from Switzerland who was diagnosed in 2006 with colon cancer, and he had liver metastases upon diagnosis already. That tells us colon cancer is very difficult to get in early stage, and often patients already have metastases. The patient refused systemic chemotherapy that was offered to him. He knew that he was in a palliative setting, and the doctors told him, with these liver metastases, you will live a year or a year and a half at max. He talked to me in length, and he told me that he would rather live with good life quality than torture himself with systemic chemotherapy and possibly live a couple of days or weeks longer. So we agreed at the end to a local regional chemotherapy, which can use much lower dose and is given through a transarterial chemoembolization technique. That means a catheter usually inserted in the pelvic artery or high femoral artery and then advanced through the aorta to the liver and used to introduce a certain amount of chemotherapy and embolic material directly to the tumor. And that treatment was then followed by so-called laser-induced thermotherapy. I have a couple of pictures here for you that shows that. Here you see one large tumor in the right liver lobe before the actual treatment. Then we have a picture on the right that shows you the catheter coming up and the contrast medium coming out and illuminating this cancerous area here. Then we have shown here a picture that is generated by an MRI computer that shows you a three-dimensional type of picture of the lesion. And finally, we have a picture of the second TARC treatment or after the second TARC treatment. We do that every 3 weeks. And you see already the tumor is majorly reduced in size, less than half. And here, this picture shows the image after the reduced tumor was then finally cooked away with laser-induced thermotherapy. And you see a bigger, healthy margin around the tumor is being destroyed at the same time. Now, this patient had a wonderful run from 2006, I think for 4 or 5 years, we will see in a second, when he started our oral medication program and had the TARC and LIT treatments done. He lived with completely obliterated metastases in the liver for many years. We added a strict ketogenic diet, which was done in a cyclical fashion, meaning 3 months on ketogenic diet and 2 months off, and so on. And we found that this patient was having a major improvement of his metastatic liver disease with full remission from 2006 until 2017. So 11 years with liver metastases. But that's not all for this patient. In 2010, the patient was found with several small lung lesions. Now, we applied the same technology here, TARC and LIT of the lung lesions, in combination with our adjusted immunotherapy protocol, and we show you the result there. This is only one image. There were 6 or 7 lesions, and all were taken care of with the same TARC and LIT afterwards. This is CT before the LIT and before the TARC treatment, and this is 3 months later, the lesion totally gone from the lungs. Following up on this patient, we can proudly say that he achieved full remission. There was no further metastases observed until 2017. In 2017, after 12 years of good life with excellent life quality and well-controlled disease, he had a progression of his lung disease, and he finally died of lymphadenopathy and lung disease. That means lung metastases. Now, the question is that a successful treatment with the patient in the end dying? I don't know. But I ask myself until today, what did go wrong? Why did we not catch this second outburst of the cancer? Maybe we find some answers in the next patient examples. This is a 62-year-old male from the USA. He comes with stage 4 metastatic bronchial cancer with a high risk of left main bronchus obstruction. And the pictures show that there is a huge left upper lobe cancer extending into the hilus of the lung here and pushing onto the left main bronchus. There you see the same picture in the axial shot of the CT in 2017. The patient declined palliative systemic chemotherapy. He agreed, however, on the same approach with chemoembolization, TARC. And this was a good decision. In 9/17, a month after he was diagnosed, he started on our oral medication and infusion therapy according to our protocols, which are shown here, in combination with TARC treatment. Here are the compounds that we use orally, and in the session tomorrow, I will talk about each of those compounds that we are using for metastatic disease. His infusion protocol consisted of high-dose vitamin C, curcumin artesunate, which is artemisinin, Q10, selenium, thymus, B complex, and a proprietary mix of hematoxylin and DMSO. I am glad to tell you more about this later on, maybe in the discussion. The patient with this combined treatment of TARC and our protocols was able to achieve a significant reduction of the primary lung lesion, and the risk of bronchial obstruction was completely gone. Here you see the angiography before the TARC to prepare that, and this is a picture 4 months later, and there's no tumor anymore, and very little remnants of the tumor in the CT scan. The patient, of course, was happy then, and there was no danger of him dying with not getting enough air. In October 18, he was started on an immune therapy with Keytruda. You remember that is the drug pembrolizumab that is one of the checkpoint inhibitors. And at the same time, we used a designer peptide vaccine that I will also talk in more detail about tomorrow in the next presentation. Under this treatment, the patient continued for about 3 years with good quality of life. He achieved stable disease, but then the disaster came. In October of 2020, he died of disease progression. I must say that this patient had other cancers, tongue cancer and esophageal cancer. And we just were so euphoric about the success, we forgot that the other cancers could creep up on the patient. And that is what happened. He basically died of the consequences of his esophageal cancer. This is a 81-year-old male from Indonesia, from Jakarta. He was diagnosed with a large primary liver cancer in April of 2016. The cancer was way too big for an operation. His AFP level was well above 1000 nanogram per milliliter, and this after a hepatitis infection that he had some 20 years earlier. The patient started on the same interventional radiology treatment with transarterial chemoembolization. He received that 3 times. At the same time, he received our adjusted protocols with oral and infusion treatment, and we followed up the Tartze treatments with microwave ablation of the large hematoma area. I show you some pictures. This is the MRI on April 16, and you see here almost the entire left lobe was occupied by the hepatoma. That shows the angiography to initiate Tartze, and the catheter goes up to the left liver artery, and the chemoembolization treatment is applied directly to that area of the tumor. Now, microwave ablation is shown here in this picture. You see here the catheter that is introduced into the left lobe of the liver directly through the skin, and microwave heat applied. That was in January 17, and the image on the right shows you the situation after microwave ablation. And here you see the end result of the combined Tartze and microwave ablation treatment with a largely destroyed left liver lobe where the hepatoma used to be. Now, coming back to the patient's data, the next surprise for this patient was prostate cancer. Well, he's 81 years old, and prostate cancer in that age group has a chance to be there in the range of 70 to 80%. The prostate cancer had a Gleason of 7, and his initial PSA was 14. So we chose for this gentleman a stereotactic radiation treatment, something similar to gamma knife for the prostate cancer. Today, his PSA is basically below 0.1, and he has no problems after the stereotactic precision radiation of the prostate cancer. All that time, from 2016 on, we also combined the interventional radiology measures with our oral protocol and with infusion treatment for this patient. And here are the components that were used during the treatment: Imusan, curcumin, artemisinin, BioBran, milk thistle, quercetin, detox-me, and asglab modified citrospectin. And again, tomorrow I will go and present more details to these preparations that are all taken orally and usually do not cause any side effects. And for the infusion protocol, we do usually 5-day blocks, and this patient has received 2 treatments per month. So 1 week on, 1 week off, 1 week on, 1 week off. And again, we used our hematoxylin DMSO according to a proprietary formula, and the other components were pretty much similar to the first patient that I showed you. This patient ended up with a complete remission of his large hepatoma, which is not very often the case for this tumor. This tumor is highly deadly when it's inoperable, and the patient is enjoying 5 years of tumor freedom today. We can proudly say that he is now living with excellent life quality for more than 5 years with a well-controlled hepatocellular carcinoma. His present AFP level is about 0.16 to 0.2. He has 3 years of well-controlled prostate cancer, His present PSA level is smaller than 0.1 nanogram per milliliter. This is a 68-year-old female from Singapore. In April of 2015, she was diagnosed with neuroendocrine differentiated carcinoma of the lung. There was a surgical removal of the left lower lung, followed by chemotherapy. Only half a year later, a solitary brain metastasis developed, and at the same time, an adrenal gland metastases and multiple lymphatic metastases were seen. Here are the pictures of this lady. CT scan of April 15 shows a large left lower lobe tumor, a metastasis in the right adrenal gland, and the next pictures show a lymphadenopathy of significant size impeding on the trachea, and also lymphadenopathy on the right main bronchus. Coming back to this lady's disease course, she had a metastasectomy of the brain lesion in Switzerland, and at the same time we started immunotherapy with a PD-1 inhibitor, nivolumab, Opdivo, and our oral medication protocol. The patient tolerated the immunotherapy at the beginning very well, but soon she developed a autoimmune type of disease complex, and her lung and her liver were attacked by the Opdivo. We had to discontinue chemotherapy, discontinue immunotherapy with Opdivo, and we had to deal with a very sick patient due to severe autoimmune processes. The oral treatment that we use to get out of this dilemma is shown here. And again, tomorrow I will explain more to these compounds. After stabilization of the autoimmune disease, which took almost 6 months, the patient had 2 years with good quality of life and a well-controlled disease. But in the end of 2018, her lymphatic metastases progressed, and the patient eventually died in April of 19. Now, that certainly is not a good cause of disease, and I think the detrimental aspect here was the development of the autoimmune disease that almost killed the patient and probably set the stage for a recurring and vicious cancer. This is a 70-year-old patient from the US and a good friend of mine. He had an inflammatory sarcoma of the larynx diagnosed in September of 2015. Biopsies were done and histology was examined at Mayo Clinic and UCLA. That was the laryngoscopy before the treatment. And you see here this cauliflower-like tumor that's sitting on top of his larynx, on top of the vocal cords, basically, that made him difficulties to breathe. He was a free diver, but he noticed he couldn't get down so much because he couldn't hyperventilate at the beginning to get CO2 out of his body for a deep dive. In October 2015, the PET scan shows suspicious lung lesion in the left upper lobe. So treatment was very, very tricky to suggest to him. In the end, he scheduled a laryngectomy with the best doctors of Mayo Clinic in Phoenix in December 15. But for some reason, he went off the operating room table on the day of surgery and decided against the surgery and came to Switzerland to see me. Now that was a lot of pressure for me. Here's a friend that the best doctors of the United States recommended to take the larynx out for a chance to survive. He has some sort of a suspicious lung lesion, but decided for that, then stopped it and took the next plane and shows up at my doorstep. In January 16, we started with oral medication and infusion therapy for him. And he did actually very well. This is his protocol, and we did 5-day blocks again at the beginning, 3 times a month and only 1 week off, and later 2 times. And today, 5 years later, he's doing 1 block every 2 to 3 months. The patient had also immunotherapy, but not with the standard checkpoint inhibitors, but rather with high dose of BioBran, Immusan, and thymus extracts. We have learned that the classical checkpoint inhibitors are not indifferent to use. There's a lot of chance for autoimmune disease, even late in the development, like for that patient that I showed you earlier. So this patient took our own immune treatment. We added autologous NK cell treatment, so we took some of his NK cells out and multiplied them in the laboratory and gave back 2.5 billion of those cells. And we finally added a designer peptide vaccine, which I also explain tomorrow in my second presentation. After 4 months of this combined treatment, there was no evidence of tumor in the larynx or anywhere else in his body. Even the suspicious lung region vanished. The patient continues today on our oral medication with a greatly reduced protocol, and he takes 1 infusion block every 2 to 3 months. And I show you his pictures. This was before we started treatment, and you see here this large tumor at the entrance of the larynx. That is a PET scan, and you see it goes above the midline, so both sides were involved. It even goes towards the esophageal tissue. So we were very afraid that he would not respond well. But this is after a couple of years, I think 3, yes, 19. There's no tumor left here. This is his laryngoscopy in 19, and here I show you a function of his larynx in a short video clip. You see the vocal cords quite normal, trachea normal. There's a little bit of the arachnople gone, but other than that, he has a well-functioning larynx. So of course, this patient is today very happy about the outcome, but is he cancer-free? I don't think so. But I think he has a non-measurable cancer. In March of 21, we cannot find any cancer. He has a full functioning larynx, and the patient enjoys his new lease on life. Here you can see him head down wakeboarding in Michigan in October 2019. The next couple of slides show the medical history and disease course of a 42-year-old lady from Germany. This patient was diagnosed with inflammatory and triple-negative breast cancer with lymph node metastases in May of 2005. She was quickly operated with mastectomy and adjuvant chemotherapy followed. However, already in February of 2006, liver metastases were shown in a MRI study that I have some pictures here for you. Here is the initial MRI with the large metastases in the right lobe, 2 smaller ones in the lower right lobe, and some on the left lobe of the liver. So significant liver disease for this patient already in 2006. The patient refused palliative chemotherapy, and we also enrolled her in our chemoembolization protocol, and Professor Vogel from University of Frankfurt was kind enough to help us with the TARC and laser-induced thermotherapy for this patient. I have some slides for you that show the TARC treatment. Here is the catheter coming up to the liver artery after injection of a contrast medium and embolizing medication. You see the metastatic areas in the left and the right lobe. Then we injected chemotherapy, and after that we have some pictures of the result of that TARC. We see a majorly reduced size of the large metastases. That is also seen here. Then we did follow TARC treatment with LIT treatment, and you see here that's the end result after LIT, which took good care of the patient's liver metastases. Now, the patient under this treatment, she was also put on our oral medication protocol, and that was with indole 3-carbinol, imusan, curcumin combi, biobran, and a precursor of our later detox-me. And again, about these I will talk tomorrow in the presentation number 2. The patient had actually a good run with quality time from 2006 until 2009. In 2009, there was an osteolytic bone lesion found in her spine at the TH12 level. In April, we did see that because she had recurring pain in that area. And here, we did not do spot radiation. We wanted to keep that for later, but we used a semi-invasive treatment with fiblaferone that is puncturing the vertebra where it's lytic and basically injecting into that area a fiblaferone, which is an interferon, directly into the bone. After 2 or 3 treatments, 2 weeks apart, we saw a good result with regard to complete pain reduction, but also ossification in that area. This is in May, so after 2 or 3 treatments, it was a very good result with regard to bone stability and with regard to pain control. Now, unfortunately, this patient, although at the beginning a good 4 years with quality of life and a good response, then finally progressed with her disease. She went to the US, started a new treatment with juicing and meditation. I think she had somehow enough of all the invasive and semi-invasive treatments she received and wanted to have a change of environment. But I should have warned her more intensely. I knew or know if disease is in the bone and in the liver, time is ticking fast and you cannot loosen up your treatment to achieve longer control of the cancer. This patient finally died in May of 2010. Of course, I asked myself whether I should have insisted on her staying and receiving more treatment to control her disease. Nobody knows whether she would have lived longer and with better time. This slide shows the disease course of a 66-year-old female from Germany, actually my first patient with metastatic breast cancer and natural treatments. At that time, in 1983, integrative oncology or holistic oncology was not thought of, and the terms were not coined yet. But nevertheless, this patient had been diagnosed with right breast cancer lump, moderate skin retraction over the lump, no nipple discharge, and some questionable lymphadenopathy on the right side in the axilla. Remember, in that time, bone scans and tumor markers were just becoming recognized as diagnostic and disease monitoring tools, and not available where this lady was at home. The patient refused biopsy and also chemotherapy, and she started with some natural remedies. From January 1984, she then also took some of the recommendations that I gave her, broccoli extract, later indole 3-carbinol, then some imusan precursor from traditional Chinese medicine, some curcumin, later MGN3, which is also known as Lentin Plus or Biobran, vitamin C, thymus extract, and some regular detoxifications, but not with the detoxifying agents, detox-me based on zeolite. Nevertheless, or maybe because of what she did, she had a very long survival, 31 years with excellent quality of life. And the patient here celebrates her 102nd birthday. And I was so proud that I could visit her for that special day. She was in good physical and mental condition. She lived to be 103 years old with a long history of metastatic disease. The last patient of our series, a 56-year-old male from Venezuela, born and raised in Switzerland. He was diagnosed in December of 1997 with metastatic prostate cancer. He had pain and a significant anemia. I will show you his bone scan from December 97. Sorry for the quality, but you see the rib cages are full. The axial skeleton is full of black spots. Difficult to recognize, I admit. But here you see that his thorax, his chest, bones, all the ribs were involved, and the head was involved, and the long bones were involved. He had significant anemia with hemoglobin in the low 7 to 8 gram percent, and bone pain when he came to us. The conventional treatment that he started with hormone ablation became quickly ineffective, and castration-resistant disease developed. After about 6 months on the hormonal ablation drugs, his PSA went up to almost 2,800 nanogram per milliliter. The patient refused chemotherapy with methoxytrone, which was the only thing that was offered at the time. Matter of fact, the colleagues at Sloan Kettering or Presbyterian Hospital in New York, where he was, and at MD Anderson, they told him to go home and sort out his affairs because he had not long to live. Oral medication was started according to our protocol shortly thereafter, in the spring of 1998. These were the compounds used, and again, I can say that I will talk about these compounds in more detail tomorrow in the second presentation. He had also received immune therapy with a DC vaccination protocol, and later on also our designer peptide vaccine, and regular detoxification. 2 months on, 2 months off, when we had the Detox Me, the detoxification compound based on zeolite available. His disease course was exceptional. Under the medication protocol, his PSA decreased from 2,800 down to smaller than 1 nanogram over a year's time. I show you the PSA course in the next slide. From spring of 98 down to 2,800, down to levels around 1 a year and a half later. And also in his bone scan, you can see there's only slight changes in the rib cage on the left, but the other metastases have kind of become invisible. At least don't seem to be active. His tumor anemia vanished. There was no bone pain to speak of, and he had a good quality of life from December 99 beginning. The outcome of the patient you will see in a short video clip. He's mobile, he's active, is back to business today, and has good quality of life. Here you see Mr. Petrini. He was kind enough to give us that interview in December of 2020 after 22 years with metastatic disease and 21 years with castration-resistant disease.
Before I was diagnosed, I felt invincible, but everything changed. I was now vulnerable, but decided to fight. I really was afraid, and I consulted physicians at famous hospitals everywhere, in the US, in Europe. Everybody said the same. You have very limited time, make no plans, prepare to die. My treatment consisted of nutritional supplements according to Professor Pfeiffer's protocol, plus hypothermia. There were no side effects to speak of. I felt good throughout, and my PSA level quickly went down to 0.
You can watch the entire video on our YouTube channel if you like so. What can we conclude from this series of patients and from our experience? I think it's fair to say that new immune therapies combined with complementary oncology measures can be beneficial for certain patients with metastatic disease. One has to be cautious because checkpoint inhibitors can have serious side effects, and we had 2 patients here in our series that had serious problems with them. The patients can develop life-threatening immune attack, which often is more difficult to treat than the cancer. Patients with metastatic disease can, however, have a significant benefit with regard to quality of life and also can achieve long-lasting cancer control. I thank you so much for your attention for that first presentation, and I hope I can see you all back tomorrow at my second presentation, Integrative Treatment Approach to Metastatic Breast and Prostate Cancer. For those who want to get more information and get in touch with us, please take down these phone numbers or emails. Thank you so much and have a good day.